Hi, welcome to my podcast, and this is the episode number 4. And my guest today, Dr. Emilio Torres from Switzerland. Hi, Emilio. I'm so happy you could make it. So let's start with PACK-CXL, and we will just go around that and talk mainly about your last publication from 2022.
Yeah.
This multi-center study. Yeah. So let's start with the introduction. So I would like you to start with the pre-story of PACK-CXL because it's a multi-center study which was conducted for the last publication. And how you decided to go to this multi-center study besides of having the data? I mean, of course, it's good to start with a multi-center study in order to have more data, more information, but in general, your pre-story in that topic.
Well, so first of all, thank you very much, Tuti, for the invitation to be
You're
here
welcome.
again with
It's
you.
honor.
And so how did we start the PACK cross-linking study? Came to a very basic question at the beginning, actually, because there was actually no study that had compared PACK cross-linking with antimicrobials, and that was the main reason. So because so far all of the other studies, there were some reports showing, so the very early reports using PACK cross-linking were done only with PACK cross-linking, but they were report, not studies. So there was still that question of clinical proof of principle and comparison with the standard care of the treatment, which is the antimicrobials, in other words, antibiotics and antifungals. And so the idea came just to compare this new technique or the application of cross-linking with something that's already established, which are antimicrobials for the keratitis, infectious keratitis. So that's how the idea came. Another point that another concern we have actually is about the or the resistance of the antimicrobials. So I did a study a few years ago in which I saw the resistance profile in the patients that were using fourth generation fluoroquinolones chronically. That means every day, and those patients were a very specific group of patients. Those were the patients that we had keratoprosthesis, and they needed to use as a routine the fluoroquinolones. So in those patients, what we observed was that up to almost 50% of those patients had already resistance to the last generation of fluoroquinolones, which is basically the best we can offer, or one of the best things we can offer nowadays. So there is a big void of discovery of antimicrobial therapies, and on the same time we are seeing the resistance increasing, and then we need alternatives. And so that was also the background about the PACK cross-linking. So a treatment that might serve as alternative from what we have, and also in the future that might be very useful when necessary. So the future will tell us.
And the study design, could you just briefly describe the study design?
There was a prospective multicentric study that we performed in different countries, and the patients were randomized. They all had small ulcers up to
4 millimeters.
4 millimeters, and they were randomized, or they would have, we provide the table, so, or they would have the treatment with antimicrobials or only with PACK cross-linking. That's the way patients were chosen.
And what was the reason that what was the reason of not using patients under 18 years old? Is it because you didn't have that much kids patients or teenager patients, or it was just in order to be precautious?
No, that's a general. That was a general precaution that almost every single initial study has. That is not to involve people less 18 years old. but there was no specific point why we excluded. That was just for this specific study and for,
Mm-hmm.
but the technique should be suitable for both or all ranges of age. But for the study itself, we use only 18 or more.
Mm-hmm. And the depth of the ulcer.
Some countries also have a restriction or restrictions
Yes.
to the age, and we tried, when conceiving the idea of the study, to make it as wide as possible, in the sense that every country could get ethical approval to win this study.
Mm-hmm.
So that's why I
Mm-hmm.
have no idea of 18 or more.
Yeah. And the depth of the ulcer in your publication was 350 microns. So, do you think we could perform this treatment in a deeper ulcers, or we can also do this kind of criterias of inclusion, the depth of the ulcer based on the standards which we have for normal cross-linking and keratoconic patients? I mean, the limit is always 400, but yeah, it's a bit the thickness. Or what can you say about that? Can we
So
make it for deeper ulcers?
yeah, so there are many questions in one, and they're very interesting, all of them. So we can do it in whatever ulcer or infiltrate we can. We just have to keep in mind that the effect will be lower. So the best effect,
Mm-hmm.
is studies show that the best effect are in the infiltrates. There are who are on the surface of the cornea,
Super. Mm-hmm.
because the light can penetrate more. So the light penetration, the riboflavin penetration, is one of the issues. So you can imagine, if a cornea is transparent, that the light goes through all the way, and
Mm-hmm.
that's why we use riboflavin for other purposes, not for infectious keratitis, but for keratoconus, so that it acts as a barrier for the endothelium. So the reaction would occur within the cornea and not all the way until to the end. Uh,
Mm-hmm.
and still we have a protection. So if we have a cornea that is opaque, or there is an infiltrate, you can also imagine that the light, the UV, cannot go through all the way. So we have dispersion of the light, and we cannot compare actually the energy absorption in those two different situations. So for a opaque cornea with infiltrate, of course, you would need much higher energies in order to reach the same amount on the surface, in order to reach the same amount of the energy at the endothelial level. So we do need more energy for the corneas that are opaque. And that also means that comparing same energies, probably, and we would have less effects if the ulcer is deep. So what the studies so far show is that superficial ulcers have better effect, and these can be a key factor on those results that were observed. The
Mm-hmm.
other point to mention is about the endothelial safety of 400 micra. So that was a general conception that all the corneas, even transparent corneas like keratoconus, uh, would need 400 micra in order to be on the safe side regarding the endothelial cells. And that was based on a very old estimation, or mathematic estimation, that estimated actually how much riboflavin would be at the endothelial level. What we have seen on the last decades, and also on the latest publication on the subject, is that instead of using the 5.4 energy that the initial
Mm-hmm.
protocols 20 years ago used to use, nowadays we have many publications with up to
Yeah.
3 times more energy. Instead of 5.4, 15 joules,
Yeah.
even in very transparent corneas like keratoconus. And we don't see endothelial decompensation. None of these studies have shown endothelial changes. On top of this, we have some latest works and papers showing that the estimation of riboflavin that had been done 30 or 20 years ago was not exactly what we should have. And now, using microscopy, they could estimate it instead of mathematically, but really with microscopy, that the epithelial concentration was much lower than it thought it would be. That means, in other words, that also this limit should be higher, because then you have less reactive oxygen species there, endothelial would be less prompt to be damaged. So we have 2 points about the safety. First, 3 points actually. First, on the corner there, with an infiltrate, we do not have the full penetration of the energy because there is dispersion of the light. Second, all the studies that have used it up to 3 times more energy that were initially proposed did not show any endothelial decompensation. And third, now we have evidence that also the endothelial cell threshold damage should be higher than thought. So, in summary, I would not be worried about endothelial cells uh, in studies that use up to these or even more joules. It's yet to be proven, but up to these 15 joules, we have enough papers showing there was no damage so far.
So correct me if I'm wrong. So as I understood, since we know already that cross-linking penetrates the cornea as a standard or normally 350 micron depths, we can also assume as inclusion criteria taking ulcers with a depth of 350 micron in order to be sure that cross-linking will go through the effect of
Yeah, you are mentioning.
UV light.
Yeah, you're mentioning probably the demarcation line. So the demarcation line of around 350 that you mentioned
Yes.
should be achieved with the Dresden protocol in average. So it means 30 minutes for 3 seconds. Every time we change this, we change also the demarcation line.
Okay.
So for every protocol, we have different demarcation line. So even if the energy is the same, uh, for the surface of the cornea, what we know is that we could accelerate the process, still maintaining the efficacy. In other words, different than keratoconus, when we make the process quicker, we lose a bit of effect. The same use of cross-linking or the packed cross-linking for infectious keratitis, we should keep, so far as we know, a very similar efficacy on the surface of the cornea. You mentioned on the depth of the cornea. On the depth, we don't have this information on how much it would be penetrated and how this would work. But of course, we have to expect a less effect the deeper we go, and even less effect if the cornea is more opaque or if the cornea is not transparent. So we have to take this in account, and that's the reason why I said before as well, the reason why deep ulcers probably would need even a second cross-linking or would have a smaller effect. So the pack cross-linking is a tool that we have and could be used for help us on the treatment. The study we did, we actually compare it as a single treatment, but we are not advocating that every single user should be used. This should be used as a single therapy. You could associate, so make a adjuvant treatment.
So this everything is clear about the depths. Do you think that we need some additional future studies where we could compare the treatment modality for different ulcers, like in order to know which one affects faster, better, and for
Yeah.
example, we have big ulcer but not deep ulcer. You know what I mean? More than 4 millimeter ulcer, but superficial ulcer. I mean, for in 200 microns. microns and compare the size, the depths, and these kind of studies. But for that, probably we need a lot of infectious corneas, and it's also not easy, probably.
Good question about how we learn how this everything works. And we are doing, some colleagues here of our group are looking at this in depth. And what we have observed, so we have only preliminary data, but what we have seen is that for every single bacteria strain, for example, we have different results. So it's not only a matter of the size and the depth, but also from the bacteria strain. And even similar bacteria have different response. What we have observed is that almost all of them have a response. Some responses are very, very good, and the others are not so good as we wish it would be. And what we also see is if we increase the energy, the efficacy also increases. If you have a larger ulcer that's only superficial, it should work better, as it would be deeper because of all those factors we mentioned before. But still, we have a lot to learn on this. As I said, for every single bacteria, the response should be a bit different, and this small difference sometimes can clinically be different, so it's hard to evaluate. But normally, it works quite good in bacteria, with some strains killing up to 99% or even more, and the others much less, and less optimal in fungals. And then for acanthamoeba and herpes, we would need a much, much higher energy. So here, especially for acanthamoeba, we also have the options of the rose bengal PACK cross-linking, which is instead of riboflavin, the PACK cross-linking with the rose bengal, and even the combination. So we have some patients that we did both of them, but they are still studies that we have to do to prove and to see the small differences. One very, very important point about all of this is when we look at, if you write PACK cross-linking in PubMed, or if you look for the results, most of the studies that were published so far had used a very low energy for treating. So when we read such articles, we have to keep that in mind. We should not expect good resolution of bacteria and infections if we use a low energy, like 5.4 joules per square centimeter. And most of the studies so far have used this energy. So we have to be very attentive not to miss this information. So that was also a reason why we wrote a letter to ophthalmology from a paper that wrote that it doesn't work for quite moderate ulcers that had fungal infections, but they use only, again, a low energy. So it's known not to be working on such cases. So we have to be attentive to such results and interpret them adequately.
So this means that we can also adjust the energy based on the particular case, based on the size of the ulcer and the depth, and also maybe the infection, which
what I would
infection
say
we are
right
dealing with.
now is that exactly what I would say right now is that 5.4 is probably not enough for most of the cases. So how much do we need? If 10, 15, or even repeated higher fluencies is yet to be known, but 5.4, so the traditional dressing protocol, is for sure a very low energy. So we should be for minimum 10 in most of the cases.
Do you think that independently of the size of the ulcer, there is some specific depths where we could say that Here, there is no need for PACK cross-linking. Here, the patient can also be okay with drops or systemic antibiotics. Because, for example, I'm just associating a bit. For LASIK surgeries, there is like a standard, like below 1 diopters. Usually, we don't offer LASIK surgery if the patient, even if the patient wants to have that. But is there any depths where you could say that, yeah, with this kind of depths, no need to go for a risk with PACK-CXL and having, for example, post-operative complications or something, because this can be manageable with a local or systemic therapy?
Well, that's an interesting question. It brings many aspects. So the results have shown that the pack cross linking works better when the ulcers, like the drops, works better as well when the ulcers are smaller. On the other hand, we receive sometimes more patients that have used everything that was possible, and then they come for a last chance, let's say, because nothing works or nothing had worked, and then they want to try something different. So if nothing have worked before, so of course we have a case that's more difficult to
But
manage.
smaller and but deeper, or smaller and also not deep?
Uh, so in those cases, we should not expect that much from something. And about the depth that you are mentioning, we do not have the answer on how. And I think, as I said before, there is no limit or specific limit, and
Okay.
don't believe we will one day find a limit based on OCT, because for every bacteria this is different, and also the age of
Yeah.
the patient, the cornea resistant, so the individual cornea resistance to digestion might vary as well. So there are many factors that play a role, and it's hard to be so mathematic in this case, I believe, like we are biomechanically for LASIK or PRK or LASIK, where the refraction plays the big role, and this corresponds exactly on what depth we will ablate. I think here it's not like a ablation profile.
No, I just wanted to go to the point that if there is some range where you just define, okay, from here,
Yeah, there is no studies
it's also okay. Just
to
was interesting.
yeah, maybe with time we know, but we would need a big number of patients. And also
Cases,
there
yeah.
is also this intervariability. So we depending on the bacteria strain, it changes a lot. So it's very hard even to make a study on this point, because the groups are normally not equal.
Yeah, but I still believe that the method is pretty amazing, because when we are dealing with bacteria, we have no idea what's going to come out of that, besides of the amount, the depth of damaged cornea, and because we are dealing with some microorganisms, and so many factors dependent on the way how these microorganisms damage the tissue.
Another advantage that you can kill more than one microorganism with the same irradiation. So you kill everything. So if you give antibiotics, you can kill one more than the others. Here, that's also the case. You can kill one more than the others, but you also kill fungi and so on. And of course, this the pack cross linking can be used together with the antimicrobial therapy, and these we had some studies, and Boris Kneizes from Israel have shown this as well, that the healing is faster when the pack cross linking was used together with the antimicrobial. So if you still use your medication and you do additionally a pack cross linking, you should have a faster healing response. So the epithelial should close faster. That's what he found on the adjunctive treatments using pack cross linking. So you don't need to use only, as I said before, and that's important. Many
Obviously.
people say we are not trying to give the message that the pack cross linking should be used only. You can use if you think it will solve, and for some regions that might not have access, but you can also use this separately and probably together, sorry, and that's probably the way to go. So a way to improve the response of the treatments in all of the ulcers, and it should be probably working better in the small ulcers as of all the other treatments do.
Is there something which you could add or you want to add with what I didn't ask?
No, so the last, only the last point that I really, or the last point I could reinforce is that one, pay attention to what you read about this. Normally, all the studies or most of the studies use a very low energy. Number two, different than cross-linking for keratoconus, the PACK cross-linking for infectious keratitis should have a very similar effect, even if you do it faster. So you can do the treatment quite fast, and even on the slit lamp. And number three or four, number three, we are of course doing more studies to know how much and how it works for every specific bacteria. So it changes if you have a bacteria or a different bacteria, and also fungi. So the depth rate changes. And the last is that also the last point is the probably, or there is something that could be improved also using rose bengal packed cross-linking together with riboflavin. We are working on this as well, and especially for acanthamoeba. So those probably could be new perspectives for the future, and hopefully you have good results of this.
And the last questions, do you think there could be a study in order to compare the age? I mean, which age gives a better outcome, like younger, under 25, between 25, 35 and over? Do you think it will change something?
I think it would be very hard to
it will give us something.
Because to just extrapolate that the age would be a factor, we would have to make all the other points equal. So same size, same depth, same treatment, same bacteria, same medication, before or after. So if we don't standardize all of this, we cannot answer this question. And I don't know if we would be able to do this in a quite, no, I'm not saying small cohort, but even moderate, we would have a very big number. And as the experience we have with this study with background linking, is that it's very hard to acquire high quality data in this sense, even though
I believe so,
we worked many years, we could not reach a high number because of the data quality. So in this actual scenario, I think it's very hard to have this answer. We could have, but it would be very hard to have this conclusion at the moment, at least.
I think we covered everything.
Perfect. Thank you very much, then. Tucci, have a nice day.
Thank you, Emilio. You too.
Bye-bye. Thank you. Bye-bye.
Bye-bye.